Okay, this is chapter 35. I'm going to go over this real quickly. This is a long slide deck, so hopefully we can review this in a timely manner. As when it warrants, I'm going to show you x-rays that will help explain some of these disease processes. Okay, so the first 10-11 slides go over signs and symptoms of pulmonary disease. This should be a review to you. If it's not, please look at this information. Slide 12 goes over VQ abnormalities, or what's called a VQ mismatch. Anytime there's a VQ mismatch, either low or high, you're going to have hypoxia. The next part goes over chest wall disorders. You can have this from restrictive disease, or you can have a flailed chest. This next slide goes over what's going on in a flailed chest during inspiration and expiration. The next part goes over pneumothoraces. You can have open or tension pneumothoraces. This is when you have air in the pleural space. If a tension pneumothorax is a life-threatening event, when you see that, you'll see a mediastinal shift. I have an x-ray here I can show you. You see this x-ray here shows the deviation of the trachea, and so the compression of the heart and the lungs here. This is air in the lung here. This air needs to be evacuated. This is a life-threatening event. Besides air, other things can cause thoraxes, hemothorax, cothorax, which is chyle, blood, pus. So anything that gets in the pleural space that causes compression of the lungs can cause issues with breathing. You'll have respiratory distress. Empyema is the pus. Then we have restrictive lung disorders. They'll go through these kind of real quickly one by one. The biggest one that you'll probably see is aspiration and atelectasis. Aspirations are pretty self-explanatory. You aspirate something, so you either have compression of either a few alveoli because of plugging to whole areas of the lungs if it's a main stem bronchus type thing. Atelectasis is when you have underventilation for whatever reason and you get collapsing of a portion of the lungs. It's usually the lower lobes of the lungs, and you'll see it right above the diaphragm. You'll see atelectasis developing there. To get a good picture of what atelectasis looks like, look at a chest x-ray of an expiratory film, and that's kind of what it looks like. Then you have bronchiectasis and fibrotic diseases, allergic type findings. When you have some, it causes edema like everywhere else when you have allergic, and then you have pulmonary edema and you have acute respiratory distress syndrome, which is because of our aspiration pretty quickly, and that's a plugging of the lungs. Then you go into which is usually caused by viruses, but can be caused by other things as well. Let me see if I can find an x-ray for that. Okay, this is an x-ray of a child with RSV, which is one of the leading causes of bronchiectasis in children for sure. And you'll see it's kind of a fluffy looking pattern around the mediastinal area. Hopefully we'll be able to see an x-ray later. They'll show a then you can get pulmonary fibrosis, which is usually the result of long-standing lung disease. Okay, and this area just doesn't move. Your lungs should be kind of like balloons blowing up, blowing down, as a very loose analogy. This tissue is fibrotic and does not move. There can be several causes for this. We all know about asbestosis and coal mining causing problems with lungs. Scoliosis and asbestosis, and that's just some more information here. This is just a question on restrictive lung disease. probably the biggest reason you think about pulmonary edema is either someone who is in congestive heart failure will have pulmonary edema, someone who has a chemical burn or a burn to the lungs will have pulmonary. It's just, when you get excessive water in the lungs for whatever reason. This too can be. So there is a little algorithm here for causes for it. And then treatment is basically treating the underlying cause, supporting the person so they can get over the problem. This is talking about acute respiratory distress syndrome, with basically you have some sort of event that causes a surfactant to be inactivated in the lungs, and so you get what looks like premature lung disease. So basically it's kind of another sort of edema, but it's on a different scale. Usually the ability to produce surfactant will resolve after a few days, and then you can go into, depending on how fast they go into, you can start getting some a little bit more about that. You're probably not going to see this in I've had it in primary care that have been very sick. Then you have obstructive pulmonary disease. They're also going to be having respiratory distress, but for a different reason. Some of the reasons that you're going to have that is like chronic bronchitis. Chronic bronchitis and asthma. I get a lot of people that say they have chronic bronchitis. What they have is uncontrolled asthma. So just be aware of that. So asthma is a disorder of inflammation and mucus. So you have inflamed alveoli, and you also have mucus blocking them. It says half of all cases develop in childhood, but the other half develop in adulthood. Okay, so we always think about that as being a kid disease, but it's not. The hygiene hypothesis, because a lot of asthma is caused by allergies. So you have allergies that cause you to start wheezing or whatever else. So there's some thoughts that if we expose people to more germs early on in life, that maybe we have less asthma. Who knows? That's one idea. So here's the thickening and the mucus. Okay. So when you're treating asthma, basically what you want to do is you want to relax the alveoli so it allows more air in, and you also want to decrease the mucus and the bronchodilator like albuterol, and then we're also using steroids. You'll learn more about that next semester, I hope. This is talking about some of the immune modulators that are going on during an asthma attack. The treatment here. Asthma is super common, so you will see a lot of this in primary care. Now, asthma is pretty good though, because there's pretty standard ways of treating it, from the mildest form, the mild intermittent asthma, to the severe asthma, and there's a stepwise approach to treatment of asthma, which makes it one of my favorite diseases, because if you treat it correctly, people do well, usually. There's always the exception to the rule. Now, one of the differences, if you do a pulmonary function testing on a person with asthma and you treat them with a bronchodilator like albuterol, they will improve. With chronic obstructive pulmonary disease, their numbers don't get as good after treatment as the asthma, and that's one way of diagnosing asthma versus this. Okay, just some more information on that. Chronic bronchitis. They don't tolerate exercise. They have shortness of breath. A lot of these people are smoking. They have polycythemia, and the reason they have polycythemia is that they're increasing their red blood cells to increase the hemoglobin carrying capacity of oxygen, because they're just kind of like chronically hypoxic. They have 1 second. That's what that means. Okay. The big treatment here is decreased smoking, bronchodilators, which is your albuterol type things. Chest PT, which is like beating on your chest trying to move that stuff around, antibiotics, steroids, candle ventilation, oxygen therapy, depending on how bad these people are. Emphysema, which is kind of most of these things I think about, like asthma, chronic bronchitis, COPD, emphysema, just on in a continuum. So if you leave asthma untreated long enough, those squamous cells in the alveoli that we talked about in the first video will become columnar cells. And so the lung is going to get stiff and it's going to start scarring down. So, if you think about these diseases on a continuum, it's better to break them in the early cycles, treat asthma correctly so that they don't become columnar cells is super important. And then this talks about emphysema. You've got so much damage here that the lungs become a little scarred. Let me see if I can find an x-ray of someone. Okay, here's a picture of someone with emphysema. You see these just large areas of lung that are just overexpanded. Okay, you can also kind of look at the top of this rib cage here, and how rounded it is. These are the people, remember, where they'll have the big barrel chest. Hopefully you can see the difference. This is a normal chest x-ray. You see that where the emphysema had that big rounded chest here, lots of dark area here, which is basically air. Where here you can see kind of lung tissue going out here. You can see a little bit of vascularity going out. So this is a normal lung. You see nice defined diaphragm here. You see the heart's nicely outlined. It's taking up about 1/3 of the chest, which is normal. You see the little aortic notch here. So this is a normal chest x-ray. Okay, so maybe you can see the difference between them. Going back to our slides, they talk about, just you get these large air spaces just because you have destruction of the alveoli. So basically you're just tearing down the infrastructure of the lungs. These people do not do well. Let me see if they're going through anything else. Then you have pneumonia. Responsible for more deaths per year than any other infection. Here's a chest x-ray of a bacterial pneumonia. You get this area of collapsed lung because you have pus and that sort of thing inside there. These people will have increased white blood cell count, usually have a fever. They are coughing, they're sick. Okay, so this isn't a great x-ray, but you still see the rounded chest up here. You see the diaphragms pretty well down here. There's a little bit of haziness right here. There might be a little atelectasis from them not breathing deep enough or whatever because of this. Let me see if I can find another one. Here's another bacterial pneumonia. You can see this area of consolidation. Now, if you have this in an adult, and that's particularly someone that smokes, you do want to get a chest x-ray several months after they get better to make sure this area is cleared and that it's not really a tumor that's hiding back there. Okay, but you have to wait several months because the x-ray does lag behind the. You'll hear us talking about atypical pneumonias or mycoplasma pneumonias. These are the ones you treat with the atypical medications. For instance, you're going to treat mycoplasma pneumonia with Zithromax. And these you don't have that patchiness like that one area there. You just kind of have a more diffuse patchiness. These people typically aren't as They're sick for sure, but they're not typically as sick. Legionnaire's disease, unfortunately, I've never seen it, but that's supposedly an x-ray of it. Here's another x-ray of mycoplasma pneumonia, just the patchiness around the perihilar area. Found another slide here that talks about, this is a viral pneumonia. You can see it's kind of patchy in the interstitial area here, and if it's better x-ray, you can probably see it's a little patchy throughout. This is the atypical, or the mycoplasma. You see it's a little bit more dense area. You see little pockets of pus or whatever. And then I'm not sure if I can move this over. On the same slide, they have a picture of bacterial pneumonia, so you can kind of see where they're going. Okay, and how you can develop pneumonia: aspiration, inhaled. You can definitely get it from, if you got somebody that's trached or whatever, they're definitely more prone to getting pneumonia. Just some of the more symptomology here. Tuberculosis is on the rise. I've never seen it, thankfully, but let's take a look and see if we can find an x-ray. This is supposedly a picture of someone with tuberculosis. I always think about tuberculosis being kind of patchy, kind of a having a cystic looking lesion, but I don't see anything here. There's something that looks cystic a little bit up here. I'm not sure that's what it is though. So, but it does have a lot of little patchy parts. There's a cystic looking lesion in there. Maybe that just goes into some of the treatments for TB, which of course we have a problem with some forms of TB being resistant to the normal treatments. Then you can have abscesses in the lungs. Those people are going to be quite risky. Now, bronchitis is almost always viral. Just be aware of that. And embolism, definitely be a frightening thing to see. Okay, some of the information about embolism. Of course, worry about that with people that have been immobile for whatever reason or have clotting disorders. Pulmonary vascular disease. A little bit more information in there about that. Cor pulmonale, that's kind of end-stage disease, not a good thing to have. So we start off with this is part of the continuum that we talked about before. So the kind of the end stage of that is cor pulmonale. Then the other thing that we need to talk about a little bit is cancer. So laryngeal cancer, remember that a lot of these are HPV. Just be aware of that. Cigarette smoking, number one reason. Small cell lung cancer is about 85% of all. I'm sorry, I misread that slide. This is talking about non-small cell cancers, about 85% of all cancer, the squamous cell cancer, the adenoma, and the large cell cancer, carcinoma. Mesothelioma, we've been talking about this with the asbestos that's in the news these days. TNM classification system does not only just apply to cancers, but to lung cancers, but just cancers in general. Okay, so you can kind of read over that. I thought those slides about lung cancer were a little confusing, so I found this that I think should help a little bit more. So you have the non-small cell types of cancer, and you basically have 4 major types of cancer that you need to worry about. Small cell lung cancer is the one that is most deadly, but unfortunately it's only 15% of cancers. Then you have the adenocarcinomas, the squamous cell carcinomas, and the large cell carcinomas. So hopefully that'll help a little bit as far as determining those.